so I don't forget. Um,
And
but we'll wait for Naj and Sue and to come back.
I'll be right back too.
Okay.
So where are all of you?
I'm in Oakland.
Uh-huh.
Oakland.
I'm in Palm Springs, California.
Mm.
Could we start again? I apologize. If you can believe it, OLOC had another Zoom program right at the same time. And it was a very important one. And I got on here exactly 4:30. And I apologize. I'm in Brookline, Massachusetts, and I don't know who Shannon and Judith are.
Oh yeah, we haven't started yet. We're just chatting.
Oh, thank you.
They are from the end of life choices. Is this end of life choice?
Fashion choices.
Yeah. I sent an email, so it has some information you can look at, but they haven't started their presentation yet. I'm waiting for we're gonna wait for um D to come back and then we'll start. We were just telling everybody where we are. Naj, where are you?
Indiana.
Indiana. So there's some people in states that are not not able to access even the limited rights we have in California, which I brought up at the last meeting that was at with that representative in LA. I was on that call and I was the person who asked the question about why isn't dementia covered?
Mm.
Why did compassion and care lobby against it being included in the legislation that was presented?
Yeah.
So we've had people from Final Exit, Better Exit. We need new names. uh, exit,
I know.
exit, no exit. I think I'm in no exit. All right, so let's start. Um, Shannon and Judith, how are you want to do this? You're just gonna work together, or did you need to share the
Well,
screen?
I think I'm mostly here because I am in the, North Bay area. So for questions and stuff, I might have relevant information. But Shannon is going to do the talk.
Okay, I'm gonna put it on speaker then, and then so
I'll be presenting. Is there I'll share my screen here. We have a slide deck that we're going to use.
oh, great.
Let's see.
Are you able to share your screen, or do I need to make you? No, it
Yeah.
says multiple participants can share simultaneously.
Yes, I'm all set here to share.
I'm assuming, Shannon, you're part of this group, not just by choice, but because you're getting paid, because you're young. So you're probably not planning on utilizing their services right away.
I love that assumption. I'm a volunteer. I've
Wow.
worked for in the hospice industry for the last 12 years, and I stopped working full time about 2 years ago. I have a 5-year-old daughter, and I wanted to spend more time with her. Um, but I had also met the founder of End of Life Choices, and she had come and presented to our team a couple times. And I became really passionate about supporting our patients with medical aid and dying. And then I decided to, help out and join that cause as well, since I do have some time right now. So while my daughter's in school, I do a little presenting here and there, and I still work in hospice part-time as well. But yes, this is our organization, End of Life Choices California. My name is Shannon O'Shea, and Judith is here as well, Judith Bishop, and we are both volunteers. I'm a board certified music therapist and bereavement counselor, and I was a director of supportive care for hospice. So I worked a lot on the emotional, spiritual side of the work. And And I, am learning a lot about medical aid in dying. Judith has a little more experience, so she's going to be my backup today, and is more local to the Bay Area as well, so can provide some insight for some more local resources. Anything you want to add, Judith, there?
No, I'm interested. I didn't know that background that you had, Shannon. That sounds like we're really lucky to have you. I am a retired nurse midwife. I delivered babies for 40 years in the Bay Area. So this is, yes, in my retirement, I'm coming full circle.
Well, it's nice to be here. Thank you guys for having us. And I'm very flexible. If you guys have questions, I would encourage you to ask them. If it's something we're going to talk about later, I'll let you know. But please don't hesitate to like interrupt or type something in the chat, whatever. I would love to hear, stories as well from you guys. It sounds like you're very well informed, which is
Yeah.
awesome.
If people raise their hands, I will call on people.
Okay, that's a great system. And so you guys can see my slide deck there?
Yeah.
Yeah.
If I go like this, does it change for you too?
Yeah.
Okay, just want to make sure. So we provide Californians the information to successfully navigate their legal end-of-life options. We have a phone number and a website, email address. We just want to encourage you guys and anyone that that could use support to reach out to us. That this is our main goal, main mission is to help provide this support in person and virtually. So we'll talk more in details about that later, but that is our main takeaway from today. We want to talk about the importance of talking to loved ones about end-of-life wishes and values, knowing the legal end-of-life options in California, and then the resources that we can provide and how we can help. We do provide free at no cost to the person who's calling or the person who's pursuing medical aid in dying or just has questions. We are a free service and it is confidential as well. We have online resources. Excuse me. We have online resources, advanced directives, different other documents, aid in dying requests, videos, resources, links, all kinds of things on our website that can help out. And then we have a large group of volunteers who are very thoroughly trained. It's really nice volunteering at End of Life Choices because it's a lot of people who are really passionate about medical aid in dying, retired nurses like Judith and physicians and advocates, people who have been in the healthcare field, not everyone, but a lot of people who've been in the healthcare field and see the importance and the benefit and want to spread the word. So we go through extensive training and here we are. So we like to start with this cartoon of the elephant who's talking to his therapist and saying, sometimes even if I stand in the middle of the room, no one acknowledges me. And I see some smiles. I'm sure that is relatable when talking about death. I always love to tell people the example of when I was in hospice, a lot of times the daughter or son would approach us before we met the patient and say, hey, don't tell mom that she's on hospice. Like, we're just going to say that you're her care team. And we would be like, okay. And then when we walked in the room, the patient would make eye contact with us and just be like, so I'm dying and want to talk about it. The patient usually just is very aware, even with a dementia diagnosis or cognitive impairment. But then the family is like, oh no, we don't want to upset mom or dad. And so we like to, kind of rip the Band-Aid off and talk about hard stuff. Some important conversations. Most people, and this was from a study back in 2015, want their lives to end. They want to be at home with loved ones. They don't want pain or discomfort, want it managed. They want their spiritual needs respected, and they don't want to be a huge burden to loved ones. So we're going to go through these end-of-life options, review the different ones. I know you guys have heard a lot of about these different things, so I won't spend too much time on the specific benefits. But if you do have questions, please ask, because me or Judith will definitely be happy to answer those questions. But I also want to be respectful of y'all's time and not be too repetitive.
Yeah, and I definitely think the VSED one we haven't had someone talk about, but we were. So I'm sure people would love to hear about that.
Great. Do you guys have any questions about just the importance of talking about values, end of life wishes? Is that something that comes up for you that you could use support on?
Can you be more specific?
Just the first part of the presentation is more of a focus on the importance of talking about how you want your own life to end and communicating that to your family and your friends and your loved ones, spending time thinking about it. And I'm just curious if you have any questions or stories about that.
It would include stuff like advanced directives. I mean, did that sort of thing get covered?
Yeah,
We haven't done advanced directives yet.
but many of us have experience or have advanced care directives, and through other groups too.
Mm.
But some people like me who are procrastinators do not.
Yeah. But we've had a few presentations that somebody that spoke about those decks of cards that I have.
Yes, that's true. I want to say here, Red Wing.
Edwin, yeah.
You know, the very cliche thing to say about it is it's better to be over prepared than under prepared, right? Like you get everything, all your ducks in a row, and it's not going to hurt anything. What I've seen a lot in hospice is when someone dies more suddenly or loses the cognitive ability to make their own decisions, it puts a lot of stress on the family. Doing a lot of work in bereavement, when a loved one dies, you really want to spend that time grieving and being with family and processing the life and the time that you had with that person. And there's so many logistical things that you already have to work out. But if that person's, funeral arrangements were set up, if you knew that that person had a list of things of like the wishes of how they wanted to die at home with their loved ones around, and you were able to know if you did things right by them. Those things can make it a little bit easier on the people that are grieving after someone dies. Does that make sense?
Yes.
Ruth, go ahead, Ruth.
One of the things I've learned is that it's not like you put this down on paper once and you should just forget about it, but periodically go back and see if you still feel the same way as when you made these wishes known. And if you have any changes, to communicate them to your family or family of choice. In the lesbian community, we talk a lot about our family of choice, but that none of this is just, done and done.
Totally.
Ruth, did you also want to ask the question you put in the chat, or do you want to wait?
I can do that. I'm wondering what the connection is and the difference is with your organization and Compassion and Choices.
Okay. So one thing I wanted to encourage you on this topic of, talking about preparing for end of life is that calling our phone number, there will be a volunteer that could help specifically with getting you the documents that you need and line items of like, hey, here are some things to review and go over. and you could have someone actually help you with more um, logistic work. I'm not familiar with compassionate choices. Judith, do you know the difference between the two?
Yes, I'll just give you a little of the history, which is many of the founders of our organization were board members and members of Compassion and Choices before we had the law. Now, once we had the law, and at about that time, and you may remember one of the ways California got the law was through the story of Brittany Maynard on the cover of People magazine and everything, the young, gorgeous young woman who had to move to Oregon with her brain tumor in order to be able to make use of medical aid in dying. Anyway, around that time, Compassion and Choices grew considerably, and now is really a national organization that really works a lot on legislative issues and so on. But what that left us with in California, now we had the law, but nobody knew about it, nobody understood it, the doctors didn't know what to do. All the sort of intimate bedside specific to California kinds of activities that had been going on through Compassion and Choices, that part no longer existed. They kind of went a different road. So our founders said, well, we've got to do something. And they pulled together and came up with something specifically for California, specifically to educate and help people make those connections. So we have a very different mission, although we work together on many things.
Thank you.
Did you agree with their lack of support of the expansion of the medical option for people with ALS and dementia? Because that was very upsetting for me.
Yes. Well, and I mean, I've heard the woman who put that measure forth, and I'm blanking on her name. I heard her speak in a way that, I mean, I was confused. Many of us were confused and conflicted because we were getting advice through Compassion and Choices, among others, that it was going to be that although we probably, most of us, support all the things, that it would freak people out in general. We had to be so careful just to get this law. Every state who has it had to be so careful to just get as much as they got. And if we went from that, this is the theory, if we went from that all the way to, having this much more open sort of European kind of access, that would, particularly in this political climate where the law may be at risk just as it is, that it would, it's sort of like saying you can have an abortion at any gestational age. They'd be saying you can, do yourself in for any old reason. You can do your grandmother in. That's the kind of rhetoric that they feared would begin, and that we would lose the little progress that we made in having the law that we have. So it isn't going away. I think they're going to work on it in a slightly different way, maybe try piece by piece or whatever. But it was felt, the concern was that it was biting off too much and that it might put what we had at risk. And I honestly can't say that I know whether I think, it seems likely that might be true because it was, over a decade just to get what we have.
Mhm.
And just to clarify, so the difference between end of life choices and compassionate care, it was compassionate care or compassionate
Compassion and
choices.
choices.
Okay.
And we are end of life choices, California. You have to have the California piece.
Right. End of life choices, California. It is, you give more
Local, we're one-on-one, we're advice and in-person help, and very different from compassionate
They're
And-
more personal, and compassion
and
choices are more
local.
legislative.
And local.
Right.
Yeah.
They're mostly working on legislation.
Right.
Okay, great. Thanks.
I'm learning too. I'm learning a lot. Thank you, Judith.
Oh,
Yes,
go ahead, Tam. Tam.
Yeah, you may or may not cover this, and it might be appropriate for me to just call. But what the question I'm having come up is, I know one person that is on her way to dying, and she's a good friend of mine, and she has never talked about it with me, and so I don't know. I've been hesitant. I mean, she will say I'm dying, but then that's it. And so I don't know how appropriate or if I could do anything to help or facilitate, or I don't know what to do. So I
sure.
don't know if you'll cover that or I should just call your organization.
I think it would be a great idea to call and have someone to talk through a couple different ideas.
Mhm.
Right off the bat, I just from my experience in hospice over the years, um, I think like pulling the elephant,
Right.
into the right and talking about it openly and respectfully is really good and healing, even if there's pain involved, even if the person receives information in a negative way or is defensive, it still is talking about it as opposed to,
Hmm.
not talking about it. I think that our website does have resources for, if you like with different questions that you could ask. Like it's designed more for questions for yourself, but you could incorporate those with your friend of asking questions that are more open-ended that could lead to discussions too. Like there's ways to kind of touch on the subject without, ripping the band-aid off and saying like, well, why aren't you considering medical aid in dying? Um,
Thank you.
I
you're
mean,
welcome.
my mom was a chaplain, and while she was dying, we didn't know how to talk to her. And she had a chaplain friend of hers come, and she really helped us. And it wasn't really religious based at all. It was just really trying to help people ask the questions and feel completed. I found that very helpful, and maybe we should have a chaplain come and talk to us too.
Yeah, chaplains, and spiritual counselors, like we call them in hospice. So it's not as associated with a religion, but it can be, if that's preferred, can be so helpful.
Do you give referrals to people like that, or what kind of, when you say you give resources, would that be one of the resources you would give?
Yes. So we can provide, even though we cover the state, we can provide local resources depending on where the patient or the person lives. So I'm more based in San Diego, so like it would be harder for me to provide those resources, but our volunteers have access to like a database and they collaborate to get the resources that are right for the person. What we don't have is like a list of all the physicians in San Francisco that you can call to ask questions to. It's more of assessment-based resources. So the person calling will be more assessed by our volunteers to see what exactly, what kind of personalized resources can we offer. Does that make sense?
Mhm.
I'm not quite clear what you mean by assessment based. And I just, if I'm confused, I'm just wondering if other
Thank you.
people are confused.
Thank you. What I mean is there's not a generic list that we would give. It would be more based on the questions that we ask the person and the answers that they give. So it's more of a personalized resource as opposed to here's the list for all of the Bay Area.
I see. So it's a vetted list.
Yes.
Okay.
Yeah. Great questions. Thank you guys so much. Okay, I think is that that's all that was in the chat, right? Yeah, there we go. So we'll go through these, starting with continuing reasonable medical treatment. So we're talking about the importance of knowing how you'd like your life to end, right? And it's important to have these conversations with your physician. If there is a medical treatment that is recommended, it's great to ask doctors questions about those expected outcomes, like what is the goal of this treatment, and make sure that the goal of the treatment aligns with your end of life goals. So this comes up in hospice a lot, where is the goal that you want more quantity or more quality of life? Like, are you more interested in extending your life with the risk of like losing the quality of life, or would you rather, have a shorter amount of days left, but the quality is better? So the best thing that you can do is just continue to ask questions, and if you need to, get multiple perspectives, different opinions from doctors. It's great to ask questions about the side effects of treatment. And to ask the whole medical team as well. Like if you have nurses, like home health nurses that are visiting, or like you mentioned, like spiritual counselors, social workers that work in the healthcare industry can help a lot with that as well.
We have several nurses in this group, just FYI.
Nice. They're a great resource too.
Yeah.
I'm sure. So we have another cartoon for continuing medical treatment, and the doc is saying, you've got 6 months, but with aggressive treatment, we can help make that seem much longer. So extending the number of days is not always unrealistic. We've had patients who are like, well, I want to make it to December so I can be at my daughter's wedding. There are some times where people do want to extend their life at the cost of the quality of life. But for the most part, the Western healthcare system is more focused on curing diseases and extending life. And if that's not your goal, then it's important to, ask those questions. Patients can stop treatment to prolong life at any point. Physician support is important here. Some examples include stopping the use of feeding tubes, IVs, and ventilators, antibiotic therapies for infections, kidney dialysis, heart defibrillator, or pacemaker. In hospice, every once in a while, we would have an extubation procedure where the family would make that decision together, and we would support them before, during, and after the extubation. Palliative care. We'll talk about palliative care and hospice care, and then the difference between the two. Palliative is focused on symptom relief, comfort, quality of life. A specially trained team of doctors and specialists work with the primary doctor. The difference is that you do not need a diagnosis of 6 months or less to live. So a hospice diagnosis has two physicians saying that a person has 6 months or less to live. And that's the Medicare qualifying you. It's mandatory in order to be on hospice care. Palliative care is not, so you can provide palliative care alongside curative treatment. But with hospice, you cannot have curative treatment and be on hospice care. Does that make sense?
Yes.
Hospice is a resource for terminally ill that emphasizes pain control, emotional support for patient and family, refrains from taking extraordinary measures to prolong life. Hospice is not a place that someone goes. Hospice usually comes to where the patient lives and visits during the week. It's not full-time care. It's they visit per need. It's usually like a nurse visits like once a week unless something comes up, and then they'll come more often. Generally assessed by physician referral, but patient can request an evaluation as well. Okay. So voluntary stopping eating and drinking. VSED. This is when a patient refuses all food and fluids. Potential option for people who do not qualify for medical aid in dying. When I first started in hospice, medical aid in dying was not legal in California yet. And we did have a patient that I remember very vividly who decided for herself that she wanted to stop eating and drinking. And so the hospice team supported her in her decision, helped palliate her symptoms, and honor her wish, support the family during that process as well. And that just helped speed along her dying process. It's not a good option for dementia patients, as you can probably imagine, except possibly under the provision of the dementia directive. So
Can
Go
I
ahead.
just say something here, actually, because I thought we had corrected this slide. Because ironically, actually, it's one of the only options for dementia. So
Yeah.
I wouldn't say it's not a good option. The problem with dementia, no matter what you look at, is the fact that you can't be too far along in your dementia when you do it, because you lose the capacity to stick to the program, et cetera. But in fact, dementia is just like before the law. Now we have the law, but it doesn't cover dementia. So it is the option for one of the only options for people who have early onset dementia and don't feel like seeing it through.
Mhm.
What is the dementia directive?
So the dementia directive, we have this resource on our website as well. It's similar to an advanced care directive where you can write down your end of life wishes within the world of dementia. Yeah, anything that you would add on that, Judith?
Yeah, it's relatively new, and it's like the advanced directive, but it tries to mostly it gives I'd say legal and emotional support again for those around you that are supporting you for it, so that nobody has any doubt that this is what you want, this is what you're asking for at a time, that you thought it through, that you know what you're doing. So the dementia directive, along with other kinds of tools, a lot of people use video now. They videotape themselves on their phones saying, this is what I want. I understand this will lead to my death. So that once they get into some state where they may not be able to communicate for themselves, they still are leaving written documentation that this is what they would choose. And it gives a lot more detail about what the person is looking for. And it's signed or notarized or witnessed just like an advanced directive would be.
Thank you. I didn't think about, my hospice brain was thinking about our dementia patients in hospice would probably not be good options for dementia patients. But yes, if you get that early diagnosis, that completely makes sense. Thank you, Judith, for that. So it is very important if someone chooses VSED to have a care team in place to help palliate the symptoms. Does require 24-hour support, and different healthcare teams can help support the family as well through that process.
Why does it require 24-hour support?
Because of the symptoms. that the person would feel. How the sorry, go ahead.
Well, can you maybe explain a little bit more about what happens, what the process is? Because if you know, or I think I would like to know more about exactly what happens and what we need to prepare for.
Sure. There's a really good video, and if I'm not sure if that link will work down there, but we'll send it to you guys after as well. That's a great resource. I don't know if Judith, do you know more about the physiological
Yeah,
effects?
this is a huge area all in its own. So I'm thinking there is a wonderful newish in Washington State website just related to VSED. And we had the woman who runs that website come and speak to our group because it's not something that any of us have a ton of experience in. It's not something that's particularly commonly done. But so it might be, since you've got your whole group around death and dying, it would be great to have her. So I'll be sure that I of course, it's something really simple like vsaidresources.org, but it's on our website, but also we can send it to you. The thing about 24-hour care is really that at a certain point, you become bedridden, you start to kind of lose it mentally. So you can't be by yourself or spending the night by yourself. You can't get out of bed or you're going to fall. You forget what you're doing and why you're doing it. You need to be reminded and supported. Don't just go get a glass of water. So that's really, it's also very helpful to have hospice or some other form of care that can actually give prescription meds, because there are periods of, my understanding is periods of agitation and discomfort that hospice would have the option of giving, prescription type medications to get someone through over the hump, so to speak. It sounds, I think to many people, sounds terrible. I have been assured that it's really not terrible, all things considered, that you get into sort of a nice state where you're no longer thirsty, no longer hungry, and you kind of float along. It takes varying amounts of time, from a few days to a few weeks, probably depending on how physically fit the person is to begin with. So if I have someone now who's considering it, and their only issue is, they're in their 90s and they're frail in a number of ways, but they aren't terminally ill. So they're kind of in this limbo land where they're being denied medical aid in dying, but they really have had it. And that person might not take so long because they're already losing weight and have no interest in eating and so on. Whereas someone with early onset dementia might be physically quite fit, and the process might take longer. So it's a really interesting, there are some books, there is this website. I would have the woman from this organization and Lisa, I'll make a note that we'll send it to you.
That'd be great. Thank you so much.
A whole thing on VSED would be great.
And thank you, Ruth Deborah, for your link to about VSED in the chat, if anybody wants to look at that too.
Oh.
The other thing I'll mention about VSED and the hospice support is, if you remember, hospice requires the physician to diagnose 6 months or less to live, correct? So if someone who is choosing VSED likely does not have that diagnosis, because that's similar for medical aid in dying. But as you go through VSED, there will be a point where a physician could probably diagnose you with 6 months or less to live. So it's kind of about finding that point where it's time to call hospice and bring in that extra support. Does that make sense?
But you wouldn't be able to get the medication to end your life in time to help you when you're starving yourself.
Right. Probably not for medical aid in dying, but you would be able to receive the hospice support for
Right.
pain management,
Pain management, noise, whatever, you know.
whatever symptom. Yes, exactly.
Just not the pills to end the life.
Right. Although there's a new article, and there are lawyers that get interested in this stuff too, lawyers and ethicists, and they are working now on something using VSED as a portal
Mm,
obtaining medical aid in dying as a different route to that. And we'll see what happens. It's complicated for many reasons. And, I just looked up the VSED resource I was talking about. It's the same one that someone put on the chat. That's it. It's from Washington State. And yeah, and I can't remember the woman's name either, but you'll see it when you go online, and she does a very nice talk. So,
But the resources that hospice offers isn't just medical. They'll provide someone to bathe the patient 2 or 3 times a week, to maybe even give respite to the main caregiver. So there's a lot of services beyond just a strictly medical or
Mhm.
drug-related service.
yes, that's a great point. The medical equipment, the supportive care team, like who I worked with, that would help a lot with the family dynamics and helping with those final arrangements and things like that. Anything else on VSED before we move to medical aid in dying? So as you guys know, medical option allowing physicians to prescribe life-ending medication to a terminally ill, mentally capable adult who has made 1 written and 2 oral requests.
Shannon, do you want to share your screen or it's not shared now?
Oh, okay. Let's try that again. I wonder what happened.
I saw it.
I
Lisa.
saw it.
I saw it too.
You're all
Yeah.
seeing the shared screen, but I'm not.
Oh.
Interesting.
We'll just do a little troubleshooting. Do you see it now?
I see it now, yeah.
Great. So these are the states that do have legal medical aid in dying. You can see Washington, Oregon, and California are in solidarity over here together. And it's been legal here since 2015. Governor Brown signed the bill and he was quoted, "I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, it would be a comfort to be able to consider the options afforded by this law, and I wouldn't deny that right to others." And yeah, he was practicing Catholic or is, and that was inspiring, to have someone because a lot of Catholicism has beliefs on medical aid in dying, but it was encouraging and exciting back then. Now it doesn't seem like we're getting quite the same excitement in legislation, unfortunately. But that's why we volunteer to keep helping spread that word and spread awareness. So some of the requirements: you have to be an adult, California resident, terminally ill, so 6 months or less by a medical professional, mentally capable of making informed medical decisions, and able to self-ingest small amount of liquid. Are you guys aware of these requirements?
Yes.
Yep.
Yes.
2 verbal requests need to be made to attending physician Kind of like we talked about earlier, if it's something that you might be interested in later in life, it's great to start talking to your doctor about it now. Because if your doctor isn't supportive, then you have time to kind of find someone and, get your ducks in a row. One written request signed by 2 witnesses. One witness must be unrelated to the patient. And physicians. So you have an attending and a consulting physician. So if someone is having a hard time finding physicians, one thing they can do is call our nonprofit and we can provide referrals to people in their area. It's a big one.
And
Yeah.
what is it that makes these people on your referral list? They're just people who have said that they agree with this, or what is it that qualifies them to be on your list?
Mm. Judith, do you have an answer for that?
Honestly, their willingness to do it.
Yeah.
So we'll discuss. I mean, there are barriers sometimes to finding a doctor, and we can talk about that specifically, but some well, let me say it now. There are some medical institutions, like anybody in this group that's in Oakland belong to Kaiser? Nobody? Well, the good thing about Kaiser is they have a system. They have an end of life program, end of life navigators. You want medical aid in dying, you're eligible for medical aid in dying, they will see that you get it. So if you have Kaiser, you're all taken care of. It doesn't matter how your individual doctor feels, it's Kaiser will get another Kaiser doctor and you will get medical aid in dying. Certain other ones like Sutter does a pretty good job. Also, they have a little system, UC Davis, UC San Diego. So sometimes the medical entity has created a system to help people find doctors if their own doctor won't do it. Your own doctor is always the place to start. Then there are hospices who have medical directors who are willing to prescribe. And that, in my mind, is where this really belongs, is with hospice, but that's not working out so well. But anyway, and I can tell you, for those of you in Oakland, again, that there are hospice options in Oakland where medical aid in dying, not that you have to do it, you never have to do it, but you're talking about having the option where that you would just want to be sure to enroll in the hospice where that was part of the package. And then the final route to finding one is there are private sort of concierge type doctors who have made a sort of specialty niche out of providing this service. It can be quite expensive. And so cost is another issue, along with the cost of the medication can be a lot. But those are the routes. And honestly, I mean, everybody has to be a licensed physician, but we can't say, oh, they're the nicest or the I don't know what other kinds of vetting you would want, but they are, they are willing to step up to the plate and do it.
And where do they get trained? Like, how do they learn that? Is there any kind of special training?
Doctors have trained each other just like we've been trained, and it's not actually, it doesn't take a lot of training. They're not, it's really assessment that you fulfill the criteria, and then it's prescribing the medication. And the law doesn't say anybody has to be with you when you take the medication. You can do it all on your own. We don't recommend it. And that's another thing that our volunteers do. We're trained and go to the bedside and mix the meds and are there when they take it. And sometimes the hospice staff can be there, but often the laws of their hospice say you have to step out of the room, you can't touch the medication, etc. So The best thing is to call us, but I'm telling you, what I'm telling you are sort of how those routes might go. I gave a talk in Marin and everybody had Kaiser, so then I didn't even have to discuss it. But to know that there are hospices and that there are private doctors, and the place to start, though, is to start talking to your own doctors about, well, if I got in this situation, this is what I would want. So how do you feel about that? Do you have any experience? If the doctors don't have experience, our organization and another organization called ACAMAID, don't make me say what that acronym is. They have mentoring doctors who will mentor new doctors who have not gone through the process, who don't know the paperwork, who don't know how it works. So we're eager always to say, well, do you think your doctor would do it if, they just don't know how? Because we can take care of that.
Ruth, Deborah, you had your hand up.
Yes. I live in an area where none of the doctors are allowed to prescribe the medication. I'm in the Coachella Valley. If people are interested from here, can they call your organization and find out the closest doctors
Yes,
that would be available?
absolutely. And I should
I've
say
had
that
people ask that. Yeah.
one thing that COVID brought us is telemedicine. I mean, now it's much more accepted, and some of these private doctors, it doesn't matter where you live, they'll do it on video or on Zoom or whatever they do it on.
Oh, that would be great.
Good to know. Yeah.
But that may be more likely to be costly.
That's the problem.
Shannon, I'm a little worried about the time. It's 2:20. I see you have a lot of slides, so maybe we could, I'm wondering how we should proceed. How much longer is your presentation? Because I think maybe I want to make sure everybody's questions are answered and that we're covering things that people want to feel they need to learn. So,
Sure. Do you want to just switch to more of a question answer for the rest of our time?
well, maybe you could just tell me us very briefly what are the other things you were thinking of covering, and maybe people can say, I'd like to talk about this or that.
Definitely. So this is more about the process for the prescription, some of the more just like psyche behind having the medication, what it would look like on the death certificate, how to talk about it a little bit more in depth. And then from there, it's just more about our volunteer program, which we've been talking about throughout the presentation as well.
Okay. People speak. What do you want to hear? Do you have questions?
Can we look at the slide about how you talk about it with people? Because I think that's what Tam was talking about, and that would be helpful to me because I also have a situation.
Sure.
And I thought that whole section of the next 5 slides that were coming in the presentation were ones I'd like to hear about.
Okay. Let's cruise through them, and then if you guys have questions, stop me. I'll do like a quick version of each one, and then we'll stop on the more of the communication piece as well. So the RX process, the attending physician provides a prescription directly to the pharmacy, and it can be picked up or delivered. Depending on the doctor, like we have a doctor here in San Diego who would go and pick up the medication herself and bring it to the patient's home. Doctors have all kinds of different ways of doing their own system here, especially when it's the private pay expensive ones, like we were saying. RX is a powder which is mixed with a small amount of liquid just prior to self-ingestion by the patient. Deep sleep generally occurs 2 to 10 minutes after ingestion and progresses to a deep coma. Death generally occurs within 2 to 3 hours for 80% of patients.
That's the outside. It's more inside. I mean, doesn't it take less time than that usually?
Sometimes, yeah. And then on rare occasions, it can take longer as well. it can depend on, there's different things advisable food-wise, like not eating a lot of really fatty foods the night before. There's different things that can affect how the medicine is ingested.
How it's absorbed.
So
Absorb.
I've seen documentaries and people seem to die really quickly, like within minutes.
Mm.
Isn't that generally more the
Well,
common?
they're in a no, I'd say they're in a coma within minutes usually,
I
but
see.
the actual death is often, yes, it can be 15 minutes or something, but it is, I'd say the average is more around 2 hours. I did have someone once after she came up to me, no, her question was, what happens to the other 20%? Because we say death occurs within 2 to 3 hours for 80%. So she was fretting about, well, what's the alternative? And was very relieved to hear that everybody died, but it was about the length of time that it takes.
And I think, Jan, didn't you have some questions in the past about the comfort level and like why is it that people they have so much difficulty finding the right drugs for people in prisons who they're executing, but they are much more able to, or hopefully they're more able to find drugs for people who are choosing to. Is there just a difference in the medication, or the other medication just not available, or do anybody know anything
I
about
think
that?
we all have that question. I have no idea.
I
Okay.
do. I do. The medication that they use in prisons are done by IVs, and medical aid in dying is not allowed to be done by IV, so it's totally different medication.
Mm.
But the problem is that the people who are done in prison seem to often have
Do so.
suffering.
Well, they have no really good solutions.
Mm.
That some of the medications are less effective or less immediately effective. Some of the states are using gas, which is horrendous, but
And what about the medications that are used in California for end of life? Are they going to be less suffering than?
yes,
And why?
yes.
Because, okay, because the
Yeah.
medication is specifically geared for that, and the prisons can't get the same medication.
Well, they can, but they don't. That because they're not intravenous medications that are used in the medical aid in dying. They're just a totally different class of medications.
I see.
Yeah, getting a prisoner to take the medication orally.
Yeah, they're not going to do it voluntarily if you're being executed.
I see. Okay. Duh. I don't know why I didn't get that. I'm asking because Jan asked, but now I see.
I'm curious about that now too. Yeah.
No, it's a good question.
Well, and it's also true because how many of us have had to help our animals go? And it seems so easy and painless, and that's IV. So
Yeah.
anyway, it's a big question for me.
And medications that they use in Switzerland are IV. You can just push the plunger. But this country's a little bit behind that way, that they're not using the medications that are more similar to the ones that our veterinarians use. Which is why my vet, when we were putting my dog down years ago, said, I just hope that when my time comes that somebody can do this for me.
Oh.
But it is much more merciful for people. I mean, for animals than people.
Well, and the whole prison system is based on suffering and punishment. It's
Right. Mm.
This is FYI, this is DDMAPH, 5 medications that are compounded into a powder. So it's, it's heart medications, pain medications, tranquilizers, things that stop breathing, things that stop. So it sort of tries to approach it from many different angles to just make sure that it happens.
So since we're talking about this, what are we talking about in terms of money for somebody who is going to pay out of pocket for something like this? I'm assuming Medicare doesn't cover it.
Right. There's no federal law, so Medicare doesn't cover it.
Okay.
But
So then,
Medi-Cal does, but there's only one pharmacy that we know of that bothers to bill Medi-Cal.
oh,
But that is one bonus. And the cost ranges, again, we only know this by getting on the phone and calling all the pharmacies. There's very little transparency or sense really about the cost. The cheapest pharmacy charges around $400. The average is around $700. Some are $800. Kaiser, again, depending on the kind of insurance you have, it'll pay for a lot of it. But the medication is not inexpensive.
and then what does, if you need to hire one of these boutique doctors, because my experience has been that that's who got used, how much do they charge approximately? Do you have a range?
Yeah, it started out that when the doctors were doing it as part of hospice, they weren't charging at all. Some of them still don't charge, but as time goes on, I'm fearful that they all hear about, oh, everybody else is charging, so it started that their way of providing it to their clients is to contract with an outside provider. So it's getting a little grayer in terms of saying, oh, get it through hospice or get it through a concierge doctor. The one that's been doing it the longest and has the biggest sort of program built around it charges $6,000. You get very good care and services and everything, but yes. And for some people, money is no object, so that's great. That's fine. Others generally start out more in the $2,000 range, but in a very short period of time, I've seen most of the ones that have done it for a while start to increase it a bit, or they charge that for themselves and then they charge for the consulting doctor and this and that. So again, why we don't give a list is that things are forever changing. So the best thing is to have a concept of how this works, and then time-wise, you call us if it's looking like you might actually have need.
And what do they actually do? All they do is tell you you're dying, put in the forms that you're dying in 6 months, order the medication, and help you find a second doctor. Is that it?
Sometimes, we have some doctors down here that will be at the bedside the day of and stay until the patient dies and help, the families and support, and even there's specifically one doctor who will bring a whole IDT with him to work with the patient. It's almost like a boutique hospice, right? And then there's the other side, like you said, where they just do the bare minimum. So it really depends on whatever package the doctors are offering with what they're charging.
Mm.
And although it seems a little gruesome here's an issue we could use help talking about, is that I do like to, so this one poor guy on the phone said, you mean I have to pay to die? He was so pissed off. And I couldn't blame him, but I did want to point out also, though, that many of these families and clients themselves are paying huge amounts of money for caregivers and this and that. So it might be ultimately, just the amount that they would pay for a week of care or something that they're no longer going to be paying for because they're going to die. But it's a little hard. I have a hard time having a good way to express that, to convince them it's a deal. you know.
Mm.
So since we're in this particular thing, so then what does your organization do? Because perhaps you can get a doctor who charges less because all they're going to do is meet with you and prescribe, and then you could get a volunteer from your organization. So
Correct.
how does your organization work in this particular process?
So our volunteers can be there the day of to help with mixing the medication and providing support to the whole family the day of. And the majority of the work our volunteers do is day of, and then providing resources and referrals to get the doctor and the team set up. Is there anything you would add to that, Judith?
No, and sometimes it is true that sometimes the doctors will say, well, if they know about us and they'll say, well, you can get a free volunteer and I'll knock so much off the cost or whatever. So we're essentially, the bargaining chip
Bargain deal.
in one way. Yeah.
Well, and didn't you say, Shannon, earlier that if someone contacts your organization, you'll assess what they need, what paperwork they need, what information they have, and what information they don't have. So there's really a lot of upfront work, it sounds like, that you do as well.
Yes, definitely. And sometimes, I mean, this is a later slide that we're already jumping into, but sometimes it's just talking about it too and providing the resources and exploring those ideas. Like often in hospice, we had a lot of patients who just wanted to know that they had control. So like a lot of times our volunteers will provide a lot of that legwork up front, and then, we might not hear back from someone again. But it's just more about that education piece and the referrals and the resources that is really helpful for sure.
And
And who contacts the most? Is it patients or family members?
Oh, go ahead. Yeah.
I do the phone, so I do know a lot about this. Honestly, it's, we used to, when I first started, we used to say, oh, we want to talk directly to the client. And so we would actually say, if someone else called, we'd say, please have them call us. And then I just finally realized that was, often the people are quite ill and they don't really want to talk on the phone, or they're really not very able to talk on the phone. So I'd say that it's probably 2-to-1 family or friend versus the person themselves. That they said to their friend, what can I do for you? And the friend said, find out how I get this medical aid in dying thing. It takes some patience and some listening, and it sounds arduous and complicated. It's not so much when you really get it laid out, but for someone who's sick and uncomfortable and so on, it's really hard for them to take a lot of this in. They just want it taken care of. So oftentimes it's family or friends.
I switched this slide because this was more in line with what we're talking about now. But having aid in dying medication is a comfort in itself, or what I've experienced in hospice, even just talking about it is a comfort as well. Helps the person have more control, and the person can always change their mind, not take the medication. Simply having it provides the comfort. 1/3 of the people who fill the prescription never take it.
Naj,
So-
you have a question?
Yeah, go ahead.
I do. I find that very interesting that 1/3 of the people who get the prescription don't take it. I live in a state where it's not legal. So this opens an interesting door for me. So I mean, I have a very medical question. If is there any visible signs that someone has taken this drug? Um, I know with certain other drugs, there is you can look at the body and you can say, oh, this person died from carbon monoxide poisoning. Yeah, so that's my question or does it just, for all anybody knows, that person had a heart attack or whatever?
Judith?
Well, so you're thinking about maybe some of that 30% could send you the meds?
No,
I
But
think that's a brilliant idea.
not particularly, but
no, so it is a good question. On one of the slides, and I'm not sure it'll still come up, but it says that one of the nice things about the law is that it does, on the death certificate, it will say the person died of their underlying cause and underlying disease. It doesn't say suicide or medication, took meds or whatever. But certainly if someone dies and no one was there and no one knows exactly why, and they weren't otherwise dying, they're going to get an autopsy or something that, yes, would show huge amounts of medication. And they would know that, yeah. So you do want to it is good to think about. And that's why people have, there's so many steps to ensuring that the person wants to do it and to protect families and other people from being implicated and helping. But, one thing is, I can't remember, you Indiana or Illinois or?
Indiana.
Yeah. I was thinking the person in Massachusetts, you can go to Vermont. You don't have to be a resident of Vermont. You have to go move into someplace in Vermont and get it there. If people have relatives, people move in with their relatives or friends in California, not infrequently, just to take advantage of the law.
So there's no resident requirement for the law?
Well, there's no resident requirement in a couple of states. Vermont is one of them. But the residency part is the smallest part of the whole thing. There's not like this horrible, you don't have to pass a big test. If you have an address and you're living with your son in Anaheim and you're enrolled in hospice, you can get transferred to a hospice in California to be with support people or whatever. That no one's going to question that. That's fine. They just want to be sure you're not picking up the meds and taking it back somewhere. But as long as you're here and dying here, and that's not a problem.
Well, I'd like to go back to my question, which is,
yes.
Depending on, I'm thinking it's in terms of me personally, I have a history of of having a heart attack and a cardiac problem, and I'm 77 years old and I live alone. So if my body were found and I was dead in bed or lying, unless there was any sign of real trauma or any sign from that's my question about this compound is there anything visible?
Not by looking at you, but Shannon, maybe from your hospice experience, I know there's certain situations where you have to call the sheriff or you have to call the
coroner.
You have to call the coroner because it's an unexplained, no one was there, no one witnessed it, you weren't dying of cancer and expected to die, or whether it requires family or other people to say, oh, do an autopsy, we want to know, or whether they would have to do one legally. It's possible they might have to do one and they would know, but what would be the problem? You'd be dead. I don't know.
You wouldn't have to deal with the aftermath, but for the most part, if you're found dead in your bed and there's not any suspicious activity and your family doesn't want to do an autopsy, then there would be no investigation. Yeah. And there wouldn't
My
any
understanding too is you don't really do an autopsy unless there's really something, seems like there's a homicide or something.
most
Even
of the
when
time.
there's a suicide, I don't think an autopsy is very rare, isn't it?
Yeah, it's usually motivated by the family. Our coroner cases were always associated with falls. So if someone were to fall and like hit their head, then it would have to be a coroner's case. But for majority of our patients, it's all just driven by the family of like, I want to get to the bottom of why, dad died.
And it says here you have, and law prohibits any impact on wills or insurance, but even so, I mean, that could be a reason Naj could ask, or someone in another state, if you had life insurance, you're talking about when you say insurance, right? That's the only case I can think of when a suicide might affect your insurance. Is that correct?
Would the insurance company insist on an autopsy?
Life insurance, right?
Life insurance.
Yeah.
Because they wouldn't have to pay out if they could prove you did it yourself.
Right.
Right. I'm not sure about that.
Well,
I
I'm
can.
sure about that. But there's all kinds of reasons that someone might
Right.
there's religious fallout for the family. Could be a big one for someone, but
I will just say
for
one
me,
thing.
it's not an issue really.
Yeah, and the other problem is that one of the whole reasons for creating this law is that so people don't have to do that, because honestly, frequently it's not successful, and then you end up in some horrible vegetative state or something, and that's even worse. So,
Right.
we want to be able to be upfront, get it done with help, and get it done right. And that's hopefully it's a small piece, but for that one group of people, this provides that option. It doesn't have to be sneaky or you don't have to risk having it fail. You could throw it all up and just be found. So hopefully we're getting to a place where people don't have to do that.
Well, only 10 states offer it, right?
Yeah, it's a pretty big, because California has so many people, it's a pretty big percentage of the population of the US in those 10 states and Washington, D.C.
Yeah.
And I can't say the next 4 years is likely to see a lot of progress.
Shannon, I just want to note there's only 10 minutes. Is there anything you needed to make sure you got to, or are you cool?
So we had one quick slide about the importance of language. And then I just want to point out, here's our phone number and our website. I'll leave this up for a little bit, and I think maybe you already have these resources, but we'll make sure to send a couple things after this presentation, including all of that. Are there any other questions before we're done?
So when you say, Judith, they're not choosing to end your own life is often not successful, but the people who do things like final exit, where they have the nitrogen tanks, or I'm hoping those are generally successful. I'm not asking, you may not know, but
Yes, no, I'm sure that is, but again, it doesn't seem like, it can't have anyone there with you. You can't have, it's just very restrictive and kind of isolating. We're so glad they exist, because again, they take care of a small group who maybe doesn't really have other good options, and they can help be sure that they're accomplishing what they want to, but it's not doesn't feel like, what we would choose if we had other choices.
Yes, but my understanding is from what they said when they came is that they actually can be there with you because they're volunteers.
Just can't touch you or
They just can't help you
right.
physically take it, but they can actually instruct you or give you advice or give you emotional support and they help with calling the mortuaries or whatever it is, disposing of the bodies. So they're
And they've been going for long before the law. So, they were for a time, they were it.
yeah. Anybody else have a question, or is there anything you didn't get to, Shannon, before?
We can go back to this slide we've said a couple of these words. We can just talk about the differences of them if you'd like. Or if anyone has a question, we can.
I have a question. This new movie that came out with Tilda Swinton, I saw the previews of it, and she's asking her friend to be with her when she dies, and she is like, it didn't say what she was dying of, but she was gonna die, and so she wanted to take the pill, but apparently she couldn't qualify for it. And so she went on the dark web and gets this pill in the movie.
Yeah.
So it's like, oh, this, of course, my question is, how much does it cost? And is it really effective, or is it, a sugar pill? So, have you heard anything about that angle?
I haven't.
Yeah.
Judith?
Yeah. Again, before the law, that people going to Mexico, getting it from Mexico or something, but it's not a pill. It's like 200 Seconal pills.
Oh.
There is no pill.
No, she said.
I know. I saw the trailer too, and I thought,
okay.
man, people do somehow get this idea of that there's a pill. Just give me the pill, they say when they call on the phone.
Oh, I see.
And it isn't a pill. I wish, but there isn't a pill. And before we got the compounded formula we use now, they would literally sit and take apart capsules and dump out the powder from about, I really don't know, 100 or 200 or some huge amount. But it's been refined over time, and this is about the best we've had yet. It's pretty good. And I definitely will have to see the movie, but I'm not sure. What country does it take place in? Is it
this country?
Is it America?
Yeah, it's just his first English speaking movie.
Oh, that's right. Yeah.
And y'all, Jan and I are gonna go at 3, whatever it is, 40 on Wednesday. And so if anyone wants to come, contact.
Where is it, Tam?
It's at the Elmwood, at the Elmwood.
I would like to go. I would go.
Okay.
One thing I did have a situation was when I first started with a therapist, I told her that I was considering the Swiss ops and she said she would have to report it. And I was very surprised because that doesn't make any sense to me. Legally, it's legal. So when you say words matter, I don't know. I also think that like you said, it's just very unfortunate that people would see this as anything other than see it as like the same way they would see someone who's trying to commit suicide when you do the Swiss option or even final exit. So it's discouraging that she was a new therapist. So, I mean, younger, new to me, but also younger. So maybe that was the problem, but I hope that that's not the general case across the board.
Yeah, unfortunately, like many of the physicians, they're making decisions based on fear of liability. And it's not it's not really justifiable, but that therapist is probably just, dotting her I's and crossing her T's to make sure she doesn't get in trouble, which is unfortunate because the best thing you can do is encourage that conversation and talk to someone about it if they do bring it up. I think, yes, like there are best practice words like medical aid in dying or aid in dying, like when you use suicide or assisted suicide, then people might have a little bit more of an uncomfortable feeling about it. Connotation matters, and cultural connotation, is really important. So yeah, I'm really sorry to hear that though. It's a shame.
I thought we should actually make Switzerland one of those other end of life options on our list, just to at least acknowledge that, again, expensive, but for some people that will be
The only option.
a good option because they will do dementia.
Mm-hmm. Yeah, there's someone in our group who's not here today, whose partner they've already signed up and they're considering it. So it's a very extensive process.
Yes.
Well, maybe we should just thank you and
Yeah.
Thank you for having us.
hopefully someone from this group will find what you do useful for them in the future.
Well, I already found the dementia advance directive and printed it out for a friend of mine.
Oh, that's quick.
Yeah.
Yeah, and Lisa, so everyone will have a way of getting the phone number and website, right? Because that's the bottom line, I think, if is to know how to reach us, and then we can fill in the.
Yes, and whatever you send me in terms of any other information you want, I'll forward. But I sent the email to everybody that had your name and the contact of the organization, but I can send it again.
And it's very helpful because to distinguish between Compassion and Choices and your group. So I appreciate learning that.
There are a lot of, there's Death with Dignity. I stumble on new organizations all the time, but I'll say to the people who are out of California state, the two people, that every state is working on a law like this. So if you did something, if you looked up end of life Massachusetts or end of life Indiana, you would find who those organizations are, and you might want to get involved and help them move the process along. You might find something worthwhile.
You mean there are end of life sister organizations, or?
Yes, they all have slightly different names, but there are organizations similar to ours: Compassion and Choices, Death with Dignity. A lot of them are called End of Life and then the name of the state. So just to Google around and see what your state has going on and who's doing what along these lines.
Well, I'm just very thankful you all here. My mom, 10 years ago, she had, the beginning of dementia in New York, and she asked me if I would help her at the end if she wanted to go earlier. And I didn't know what to say, because it was New York, which is surprising to me that New York isn't one of the states that has this, but.
Right.
Yeah. And again, she had dementia, so that was, I know that this is I don't want to feel like I'm beating a dead horse, but I will continue. I wrote a letter to Compassionate Choices or Compassion and Care, and I didn't hear back from them, but I just really was shocked when I found out that they didn't support it. At least make it clear that they're going to try to get this through, because dementia is a tsunami of dementia patients in people over 85. So it's really excluding a huge population. And I understand it's difficult. I'm not saying I don't understand it's difficult, but maybe they need to separate themselves from the group, this cause, because they are not the owners of this cause.
Right. That was another thought, was to take dementia and make dementia its own thing.
Exactly.
And we, none of us would have a problem with that if that is a better way to go about it.
Yeah. So hopefully that is going to happen, because I think a lot of people with dementia are worried about it.
Yeah.
Yeah. Well, and one of the problems that all of the end of life options has is that the Catholic Church, I hope nobody's offended by this, is a very, very powerful lobby. And they have been lobbying against medical aid and dying forever and ever and ever. And that is one of the reasons why states like New York or others do not have the laws in place, because they have that kind of power.
Yeah. Well, I just really appreciate what you're doing, and the fact that you are volunteers is amazing. And just grateful to you all, and appreciate you coming to talk to us. And I will put this on YouTube. And I noticed, even though I will make it public, if that's okay with everybody in this group. Your face won't be on most of them, but that I noticed when I put it on before, 50 people looked at it who were not in this group, so that's great. And any final questions before we stop?
No, but thank you very much.
Yeah.
You're welcome. It was nice to meet all of you. I'm just suddenly thinking of it being on YouTube. All the Q&A is on it too.
I had made it private, but then some of the people in this group said they couldn't access it.
Yeah.
So I'm still.
That's okay. I wondered if I was, in a moment of humor, might have said something that.
Then I'll make it private.
I don't know. Maybe you should just look at it and see if someone's if there's any, you know what I'm saying? If we were.
Yeah. Lisa, why don't you forward it to Judith?
Yeah, I'll forward it to you, Judith, but I'll just make it private so that only people in this group can look at it.
Yeah.
Yeah, in your organization, you mean?
No, I just mean this small support group. There's only 15 of us.
Forward it to Judith and let her make the call, whether it should be private or public after she's seen it.
Well, Judith, do you want to watch it and to make that decision? Because it's a lot to watch. I mean, it's not that simple much.
Well, tell me I'm being silly. I just remember being a little frank about the fact that someone would be dead and they wouldn't be.
Judith, you have total control over this. I don't have any problem with that. I think that's appropriate.
Yeah, I mean, we can just make it private to just the people in this support group. It's just a small support group as an offshoot of OLOC.
Because I wasn't really thinking of the world at large as talking to you women. That's right.
Right. Lisa, somebody cannot forward a private YouTube.
Let me end this recording.
Yeah, that's